Hello from Boston. Today we're with Dr. Dale Adler, who is Professor of Medicine at Harvard Medical School and Executive Vice Chair, Department of Medicine at Brigham and Women's Hospital in Boston. Dr. Adler received his MD at Weill Medical College at Cornell University. He did his residency in internal medicine and fellowship in cardiovascular medicine at Brigham and Women's Hospital in Boston. Dr. Adler's clinical and research interests are in cardiovascular disease, specifically complex coronary artery disease, diabetic heart disease and its prevention, and valvular heart disease. Dr. Adler also has extensive experience in managing healthcare organizations and integrating hospital networks. Dr. Adler, thank you and welcome.
Thank you very much for having me.
Let's start with valvular heart disease. My mother had mitral valve repair at Brigham and Women's Hospital several years ago, so from a patient perspective, I learned just how intricate and how well timed and choreographed the whole process of managing valvular heart disease has to be in order to benefit fully the patient. But not everyone needs the surgery right away. So what is the role for medical cardiovascular treatment in valvular heart disease, and how it's best to prepare people for surgery and manage them in post-operative period from a cardiovascular standpoint?
You're asking a very interesting question in the entire realm of cardiology. And if we talk about mitral valve repair, you have to realize, and I'm sure you do, that 2.5% of males and 6.5% of females in this country have mitral valve prolapse. And in fact, if you examine people, and this was done many years ago with young people coming into college, and people did a careful listen, and they said, my goodness, 15% of these people have a mitral valve click. Now, there's 15% who have a click, but like we said, the numbers, 6.5% in women, 2.5% in men, are much lower for who actually has real mitral valve prolapse. But the real numbers are that out of all those people, 90% of them will do perfectly fine throughout their lifespan. And it's really only 10% of those people, so it's becoming a progressively smaller number, who actually will really need attention to their valve. And so whenever we meet patients, take a good listen, realize they have mitral regurgitation, they have an echocardiogram, you find out, yeah, they have what we call classic mitral valve prolapse. The leaflets are thickened and there's some amount of prolapse. The leaflets open perfectly, they move from exactly where they're supposed to be, open up nicely, but when it's time for them to close, one or both of the leaflets will bow backwards into the top chamber of the heart on the left side, and there'll be a leak. Most of those people aren't going to need anything done over a long period of time. And so the group you're interested in always is the group that's symptomatic. Of course, if somebody says they're short of breath, or if they're fatigued, struggling, we're interested in them. Or if they have a leak that's severe enough so that over time we're realizing that their heart chambers are enlarging. And along with the enlargement can sometimes come an increase in the pressure in the lungs, and sometimes when they stretch the top chamber of their heart on the left side, they could start to have rhythm disturbances. So that's really the group we're interested in. Now, your question, how can you prevent that? Are there medical solutions? Probably one of the most important lessons we've learned over many years is that if that process is going on, so the leaflets are prolapsing more, they are having a harder time keeping the blood moving forward, the chambers are starting to stretch, then it's a mistake to try to use medicine to manage the people. So we could use diuretics, we could make the heart a little smaller, we could use ACE inhibitors, unloading agents, make it a little easier to allow the heart to pump the blood forward, and a person might feel better. But even though they'll feel better, that underlying process with the heart stretching, getting worse, will still be going on. And it's been shown very nicely that if you are doing that, if you're treating a bad valvular disease, you're not doing the person any favor at all. Eventually, they just get worse and worse.
So in other words, if there is a mechanical problem in the heart that's been identified and there is evidence, presumably by echocardiography, that it's getting worse, as well as by the clinical examinations, the most important thing is to focus on treating the mechanical problem, and then only after that to give a medical support to the heart.
Correct. And one caveat, one area to be careful. So you can have somebody who has what seems like very severe mitral regurgitation. They feel very well, and their heart isn't stretching. And it always is very nerve-wracking to say, oh my goodness, there's a severe leak. They feel fine, their heart isn't stretching, the pressures in their heart are good. Shouldn't we correct it? And there's a lot of discussion. And in this country, when people write guidelines, what they say is, well, if it's a severe leak, even though a person feels fine, even though the heart isn't stretching, if you're very sure you could repair that valve and repair it very safely, then it's okay. It's okay to go ahead and consider repairing it. And I think we just have to be very cautious with that approach. So with what you said, I would just add, in addition to the severe mechanical problem, something else that shows you the way the heart is integrating it. If the heart is integrating it in a way that tells you the heart is suffering, then absolutely it's a mechanical solution. Don't try to use medications for it.
Let's speak about other familial colorectal cancer syndromes. And you are a world-renowned expert in colorectal cancer genetics, but your lifelong interest and achievements in colon cancer treatment and research are driven not only by scientific curiosity, but also by your personal history of your entire family. You have just published a book, Cancer Family: The Search for the Cause of Hereditary Colorectal Cancer, and in that book you tell a dramatic story of several generations of your own family with many family members stricken by colon cancer at a young age. And we already spoke about one familial colorectal cancer syndrome, the Lynch syndrome. But Lynch syndrome is responsible for about 10 to 25% of cases of familial colorectal cancer where the cause could be genetic or inherited. What do we know about other genetic causes of colorectal cancer that might run across the several family generations?
Well, understanding the problem of hereditary colon cancer has taught us a huge amount about the pathogenesis of colorectal cancer. So the very first gene for hereditary colon cancer that was found was the APC gene, and germline mutations in the APC cause familial adenomatous polyposis. And what happens is when you have an inactivation of the APC gene, you get excessive uncontrolled proliferation. And so you get lots of polyps, and eventually the polyps will grow, and since you have so many of them statistically, even though one by one any given adenomatous polyp is relatively unlikely to become a cancer, when you have so many, it becomes an overwhelming likelihood that you'll get cancer. So it's completely based upon alterations in the regulation of growth. In the case of Lynch syndrome, the problem is completely due to a DNA repair problem. And so adenomas occur at an ordinary rate so far as we can tell, but then those adenomas are very likely to become malignant in a short period of time because of a DNA repair problem. And then interestingly, there are some other relatively uncommon hereditary colon cancer problems that have to do with completely different genes altogether. And they are pretty rare, but one of them is juvenile polyposis syndrome. And there are a couple of genes that can do that, and those are inactivating mutations in genes whose job it is to be a tumor suppressor gene. So you lose the tumor suppressor, and cancers can occur. There's another germline mutation in a gene that's a kinase, and when that is inactivated, You get Poit-Jaeger syndrome. So as we've uncovered the cause of each of these syndromes, we've learned more about colon cancer. And the unexpected part is that these cancers are really, we always thought that colon cancer was one uniform kind of illness, but now we know that it's really a collection of pretty diverse diseases, which explains why some cancers respond to the usual therapies and some don't at all. They're just different.
And obviously, in familial cases of colorectal cancer, the age of onset is earlier than usual.
Right. One of the very interesting aspects of understanding the pathogenesis of colorectal cancer is that the sporadic cancers that occur in the general population without a specific germline mutation, they go through the same general pathways as the familial ones do too. They just occur later because you have to have acquired mutations in both alleles, both copies of the gene. So, for example, in most people who have a sporadic adenomatous polyp, you get biallelic inactivation of the APC gene. So something happens to one allele and then something happens to the other. That can be mutation, it can be deletion, it can be methylation. But if a person has familial adenomatous polyposis, they're born with a germline mutation in one of those alleles. So every cell in the entire colon is already primed and has a head start down that pathway, which is why the likelihood of getting a cancer is much higher and why the onset occurs earlier.
So obviously, if somebody knows of the family history of colorectal cancer, especially at younger family members, then it should be a vigilance and surveillance and visit to the physician with a potentially preventive program to identify potential precancerous lesions.
Right, and when the family history is suggestive, or if there are some biomarkers that we can find, microsatellite instability in a cancer, when those are present, then germline testing is appropriate because that will tell us whether or not this person has a very high risk of cancer and will also alert us for siblings and children to be tested, because when you find one of these germline mutations, then every first degree relative has a 50-50 chance of inheriting the same gene and having the same risk. And if we find out about this before the person ever gets sick, then you can completely change the natural history of the disease. It might involve more colonoscopy. It might involve a preventive operation, but it will keep cancer from ever occurring.
Cancer genetics and genomics is a driver in cancer diagnostics and treatment revolution, the precision medicine. And most attention is focused on mutations in tumor-causing genes. But you have extensively studied another major form of genetic changes in colorectal cancer called epigenetics. Epigenetic mechanisms act as an off-on master switches for cancer-causing or cancer-fighting genes. And as such, epigenetic mechanisms are very important for cancer initiation and cancer progression. What are the main epigenetic factors in colorectal cancer, and how does epigenetic information help to prevent, diagnose, and treat colon cancer?
So epigenetics is the study of alterations in gene expression that occur without a change in the DNA sequence. And the principal epigenetics, or let's say the first epigenetic phenomenon that was discovered, was DNA methylation. So there are DNA sequences that consist of C's and G's, or so-called CpG sites. The C is for cytosine, the P is for the phosphodiester bond, G is for guanine. So CpG sites have been edited out of the genome, and the ones that remain are mainly in the promoter regions of cells. And when the cytosine becomes methylated, so there's a methylation step that can occur that's very carefully regulated. If you methylate many of the cytosines in the CpG sites, it changes the configuration of DNA, turns off the promoter, so that on-off switch is now locked in an off position, and that silences that gene. And if certain genes, the cells trying to silence them, for normal physiological purposes. You don't need most genes in most cells. But when, in certain instances, maybe due to excessive inflammation, largely we don't really know what causes it, but in some instances, this DNA methylation becomes excessive and it starts to shut down genes that the cell really needs to be successful. And when that occurs, you can turn off tumor suppressor genes, and a cancer can occur by silencing some constellation of tumor suppressor genes. And when that occurs, we call it the CpG island methylator phenotype, or CIMP. And in probably 30 or 40% of cancers, this is a major part of what's driving this. We kind of got, our awareness of the CpG island methylator phenotype was immediately alerted because in the study of Lynch syndrome, it was found early on that about 15% of all colon cancers had microsatellite instability. In other words, had the features of a Lynch syndrome tumor, but we were pretty sure that that was too large a proportion, that many people probably didn't have Lynch syndrome. And what we found was, of that 15%, only about 3% have Lynch syndrome. But another 12% get methylation and silencing of one of the DNA mismatch repair genes, specifically MLH1. And so that tumor not only has the CIMP background, has lots of methylation. After that happens for a number of years, just by accident, we think both alleles of the MLH1 gene are methylated and silenced. Now you get microsatellite instability layered on top of it too. So that was probably the first big step forward, was understanding the MLH1 gene and realizing that there was methylation going on there, and then finding that other tumor suppressor genes like P16 and others were frequently methylated in cancer. So that was a big part of epigenetics, was looking at the methylation. The second big advance in epigenetics was recognizing that some of the non-coding RNAs in our nucleus makes these very short RNA molecules that are called microRNAs. And so they get transcribed and processed down to about a 20 base RNA run that forms into like a hairpin, and the feet of the hairpin can interact with the 3' untranslated region of messenger RNAs and leads to their degradation. So it's a big part of regulating the expression of messenger RNAs. We spend a lot of time understanding what turns on messenger RNAs, and once they're on, there has to be a way to turn them off in order for the cell to regulate processes. And one of the big parts of this regulation is microRNA expression. And the interesting thing about microRNAs is that there's a complementary recognition between the feet on the microRNA and the 3' untranslated region of a messenger RNA. But one microRNA can interact with dozens or maybe 100 or more messenger RNAs. And so the turning on or off of a microRNA can help orchestrate the expression of lots and lots of genes. And it turns out that cancers often have specific patterns of microRNA expression, and that helps us understand a little bit more about the behavior of tumor cells.
So in microRNAs, as I understand, can also regulate the response to the certain treatments, and it's also that the methylation of DNA is not permanent. It's something that you have discovered in many of your works, that it is a process that can be affected.
Yes, that's a really good point. Specifically, if you get a mutation or a deletion of a gene, it's very hard, almost impossible. At least it's very, very hard to imagine ways in which you can undo that. So you got a specific point mutation. The likelihood that you'll get another strike at that very spot and correct the error, it's too small to be imagined. Likewise, the deletion of a gene is there are mechanisms whereby there can be gene duplication and you can replace a missing gene, but those are unlikely to occur. in the case of DNA methylation, we know that some colon cancers are driven by excess methylation, but that methylation has a process whereby the DNA methyltransferase puts the methyl genes, the methyl groups on, but there are demethylases that can take them off, and that can be manipulated. So the intriguing part about DNA methylation is you can reverse it too. And we have drugs in the laboratory that can turn it off. Some of those drugs have been used in people. They're kind of toxic, but we can do it. But now people are thinking about drugs or even foods or naturally occurring compounds that can manipulate methylation. And so if we can find something that's safe that can alter this in a predictable way, then we'll be in really good shape.
So that's a very interesting, exciting, and important direction of research, and potentially even dietary regulation of methylation. That will be important not only for colorectal cancer, but for other types of cancers potentially as well.
Yes, definitely.
Hello from Boston. Today we're with Dr. Dale Adler, who is Professor of Medicine at Harvard Medical School and Executive Vice Chair, Department of Medicine at Brigham and Women's Hospital in Boston. Dr. Adler received his MD at Weill Medical College at Cornell University. He did his residency in internal medicine and fellowship in cardiovascular medicine at Brigham and Women's Hospital in Boston. Dr. Adler's clinical and research interests are in cardiovascular disease, specifically complex coronary artery disease, diabetic heart disease and its prevention, and valvular heart disease. Dr. Adler also has extensive experience in managing healthcare organizations and integrating hospital networks. Dr. Adler, thank you and welcome.
Thank you very much for having me.